Jeshman, please start.
Dr. Tanushri? Hello?
Yes, ma'am.
Dr. Tanushri, you can start now.
Yes, ma'am. Yeah. Hello. Good evening.
Yes. Little louder, please.
We cannot hear you, Tanushri.
Yeah, unmute kara, madam.
Tanushri ma'am is unmute only.
Now?
Be little louder.
Yeah, sure.
Yeah, now we can hear you.
Okay, ready?
No, we cannot hear
Still,
you.
yeah, it's still not audible.
Yeah. Is it audible now?
Yeah, it's better.
A very warm welcome from the Maha-IIT Women's Wing, all the dignitaries, esteemed speakers, and viewers from all across the state for another interesting Thursdays. I'm Dr.
Madam, you're not audible.
Yeah,
Just
the
speak
voice is
speaker.
quite feeble actually.
We can remove the.
Please detach the device. Please
Device.
detach the device.
You can directly go for speaker.
Yeah. Am I audible now?
Yes, very clearly, very clearly. Yes.
Thank you. A very good evening, everyone. A very warm welcome from the Maha-IIT Women's Wing to all the dignitaries, esteemed speakers, and the viewers from all across the state for another interesting episode of Thursday Thrill. I'm Dr. Tanushri Mukherjee, EB member of Mumbai IIP and a member of the Maha-IIP Women's Committee from the MMR region. I'm very grateful and honored to be your host today. Before we start our program today, we would like to offer 1 minute of condolence for the air crash that has happened today in the Ahmedabad just few hours ago. And that was carrying almost 241 passengers, and almost all of them has been feared dead. Only one survivor. And unfortunately, that plane has crashed on a medical college. So we really don't know about the medical people casualties till now. Moving on, for our today's topic is our pediatric endocrinology, which is considered as one of the very interesting and somewhat little intriguing subject of pediatric subspecialty. As we know that it encompasses different disorders of growth, puberty, thyroid, diabetes, calcium, as well as different electrolyte abnormalities. And these are the commonly encountered problem in our day-to-day practice that we see in the in-house as well as in the OPD practice. Today, we will cover very interesting two topics of congenital hypothyroidism and a precocious puberty. Now, I would like to request our President Maha-IIP, Dr. Sanjay Pakmore sir, for his welcome address. Sir, over to you. Thank you.
Thank you, Tanushri. Condolences to the departed souls. Means this program of Women's Wing, especially the various days celebrations by CIP and the different systems we are covering. In last time we covered the nephrology and this time the endocrinology. And these two topics today selected are the congenital hypothyroidism revisited and the precocious puberty are both very important topics from the pediatric point of view, because both these topics have somehow some emotional problems or emotional distress in the children who are we're treating. And all the endocrinological problems are very important for the pediatrician's point of view, because if we diagnose early, if we do the referral at the right time, then we can get the wonderful results. We can do the justice with the patients. And if we fail to diagnose, refer at the appropriate time, then we might not be doing the justice with the patients and the family and the society. So we must know what is there. And these two, congenital hypothyroidism, a very treatable problem where if we diagnose early, means definitely will require that treatment for the longer time, for the lifelong treatment, but still the patient can be reached to the normal milestone as his peer grows like that. In the precocious puberty also, if so many problems with the peers, parents have problems carrying a lot of emotional distress to the family, but with the treatment, we can make them normal, because in the precocious puberty also, the ultimate stature attained by the children is very much less than people of the normal means, achieving the puberty at the normal age. So all these things can be dealt very well. And today we got the two experts, one from Mumbai and one from Gurugram. They are going to enlighten us, and definitely they are going to add us to our knowledge. So how we can better do, so that we can better treat from tomorrow onwards. Thank you. Over to Tanisha.
Thank you. Thank you so much, sir, for your words of wisdom. Thank you. Now, I would like to request our very dynamic Secretary General, Maha IP, Dr. Amol Pawar, sir, for his opening remarks. Over to you.
Thank you. Thank you. Thank you, Dr. Tanushree. First of all, I welcome today's experts, Dr. Abhishek Kulkarni, sir, pediatric endocrinologist from Mumbai, and also my dear friend, Dr. Ganesh Jevlikar, who is our own from Maharashtra, who is settled in Gurugram, and also this year's Women Committee, Maharashtra IP Women Committee, under the chairmanship of Dr. Jayashree ma'am and Dr. Amog ma'am, they are doing wonderful job. And as President sir has told, they are coming up with various ideas and various programs they are conducting. So this is also one of them, and both the topics are very practical topics which will be useful for many of the pediatricians in their general practice. So without wasting time, I request Tanushree ma'am to conduct the further proceedings and to call Dr. Sanjay and then experts and all these things. Thank you.
Thank you. Thank you so much, sir. Now, I would like to invite our convener, Maha IAP, Dr. Sanjay Deshmukh, sir. Sir, over to you, sir.
Good evening. Firstly, our heartiest condolences to the departed souls, and we hope many more students will get the good news of survival. On behalf of MAHAIP, it's always pleasure to associate with a women committee. They are always on front foot on Thursday field, and they always make sure the academic will go on in auto mode. So hats off to our chairperson, Dr. Jayashree Shivakar Madam, co-chairperson Amog, and today's MSc, Dr. Chatterjee. And this is a platform where the young brigade like Dr. Abhishek and Dr. Ganesh, both are from Maharashtra. That's a great thing. And they will be give insights on the endocrinology. So welcome to the MAHAIP platform, and congratulations to the MAHAIP and Women Committee member. Thank you.
Thank you. Thank you so much, sir. Thank you. Now, I would request Jaya ma'am for a few words. Jaya ma'am is chairperson of Women's Committee Maha IP, and ma'am inspires us with her constant academic activities, great enthusiasm, and lots of support. Over to you, ma'am.
Thank you. Thank you. First of all, I welcome all of you. We all know that it is with heavy heart we are conducting this meeting today, and thank you all who are attending the program today. Dr. Amog and Dr. Tanushree both have taken a lot of efforts to put this program in front of you. So I'm thankful for all encouragement you have been giving, and the topics are wonderful. And thanks to speakers for sparing their time. And now let us go ahead with the program. Thank you.
Thanks, ma'am. Thanks. Now, I would like to introduce our today's moderator, Dr. Amog Sahane. Dr. Amog is a pediatrician and adolescent expert from Navi Mumbai, and she is co-chairperson of Women's Committee Maha IAP and Joint Secretary of Navi Mumbai. Over to you, Amog.
Thank you, Tanushree, and a warm welcome to all of you for today's session. First of all, I would like to thank my IP, Dr. Sanjay Pakmode sir and his team for giving us the Women's Committee this academic fees every month, which are attended by so many delegates. Secondly, I would like to thank both the speakers for sparing time from their busy schedules to join us today and share with us their pearls of wisdom. And I would also like to just inform all the delegates who joined us today on the Zoom platform as well as on the YouTube channel to kindly post all your questions, which will be taken at the end of both the speakers' talks. So moving on with today's session, I would like to welcome our first speaker for today, Dr. Abhishek Kulkarni. Pallavi ma'am, if you can show the CVs. Dr. Abhishek Kulkarni is the Associate Professor and a Senior Consultant, Pediatric and Adolescent Endocrinologist, and the Postdoctoral Fellowship Program Director at SRCC Children's Hospital, Mumbai, Reliance Foundation, and an Honorary Consultant at Apollo Hospitals. And he has been actively working in the field of pediatric endocrinology since many years, invited as faculty for more than 100 national and international forums. And he has published many journals, and his forte is basically research. So a warm welcome to you, Dr. Abhishek, for joining us today for today's session. I would invite you to start with your talk. Thank you so much.
Thank you. Thank you, Dr. Mo. Thank you to the office bearers of Maharashtra IAP, particularly the Women Committee, for having me here today evening. And yeah, I do agree the mood today is a bit somber because of the news of the air crash and the collateral damage at the medical school hostel. So a moment of grief there. And but what we have in our hand is to prevent further morbidity by screening babies correctly. And I thought it would only be appropriate to do the session. So without without wasting much time, let me speak about congenital hypothyroidism revisited. And why I call it revisited is quite a few of the concepts have undergone change in the recent past. And it would only be appropriate to highlight to the audience regarding the same. So I'm going to outline my presentation under the following headings. First is to emphasize to the delegates the benefits of screening, timing of screening and the analytical methodology that needs to be used, protocol for recalling neonates based on the results of the screening tests, and decision to initiate treatment based on the results of confirmatory testing. So this is important. We do not initiate treatment based on the results of the screening tests, but recall infants for confirmatory testing and then base our decisions on those. Evaluation for etiologic stratification. And lastly, but most importantly, timely treatment and monitoring of these infants who are diagnosed with congenital primary hypothyroidism. So this is what used to happen when we were students in the medical school, which was the pre-screening era in India. Only those with family history of thyroid disorder, certain ethnicities, wherever there was history of consanguinity or a mother with pre-existing autoimmune thyroid disease, or those belonging to the iodine deficient belt were screened. Or if at birth the attending pediatrician realized that the length of gestation, the birth weight was unusual, he or she would ask for screening. Or if the baby exhibited large fontanelles, macroglossia, hypotonia, goiter, or if during subsequently while examining the baby, poor feeding, dry mottled skin, umbilical hernia, jaundice, constipation were noted, the baby was screened for primary congenital hypothyroidism. But the reality is these symptoms and signs are seen only in up to 15% of the babies affected with the condition. 85% of them are going to be asymptomatic and look apparently healthy at birth. This was realized by clinicians in the West way earlier than in our country. and look what screening did to the estimated prevalence of the disorder and implications on IQ scores in the West. So the estimated prevalence of the disease was perceived to be 1 in 6,500 live births prior to the advent of screening, which was then realized to be 1 in 2,500 live births after the presence of a formal screening program. Now, most importantly, please look at the mean intellectual quotient of babies in this cohort. It was 86 prior to the advent of screening. And in the screening era, the mean IQ of these babies is 105. Please note these are the medians or the means, and there are going to be plus standard deviations and minus. And most importantly, in the pre-screening era, 8 to 27% of the babies in this cohort were diagnosed with IQs less than 70 or what was defined mental retardation. And after the advent of screening in the West, if you see, there are no babies with frank intellectual disability or mental retardation, except the syndromic ones or those conditions where prognosis is predetermined prior to the initiation of treatment where mental retardation is noted. So this is to emphasize to the delegates the importance of screening, the understanding of the condition, and obviously mere elimination or reduction of mental retardation or intellectual disability in this cohort of children. So this is the Indian scenario, and you can see that the estimated prevalence in India is believed to be far more than the average Western prevalence. Our data from centers which have done large follow-ups and screened a large number of neonates and also used cutoffs of TSH which are similar to those recommended presently, estimate the prevalence of this condition to be between 1 in 1,050 to 1 in 1,300 with a median of 1 in 1,100 live births, which is practically double of what is seen in the Western cohort. Now, once we've understood the importance of screening, the question next is when and how and what to screen. So please understand the prevalence of 1 in 1,100 live births is that for primary congenital hypothyroidism, where the gland is either dysgenetic or has thyroid dysharmonogenesis. We are not talking of secondary or tertiary congenital hypothyroidism, the prevalence of which or the incidence of which is 1 in 50,000 live births. That's a rare entity. But we are talking of the primary congenital hypothyroidism, which is routinely encountered by pediatricians and neonatologists in clinical practice. So screening must be performed day 3 and beyond. This is done to obviate the physiologic surge of TSH, which may then be falsely identified as thyrotropinemia or an elevation in the TSH. So after the first 48 hours, the sample for screening needs to be used. If a formal screening program is not in place and you fear the babies may be discharged early and may not come for a follow-up to you, you can also collect the cord blood. The cutoffs are similar, but mind you, from the cord blood sample, only screening for primary congenital hypothyroidism can be performed if the TSH is estimated, and screening for other inborn errors of metabolism cannot be performed from a cord blood sample. The upper limit of TSH in the first 2 weeks of life is 20 MIU per ml of serum units, whereas that after the second week of life is 10 MIU per ml of serum units. Now, this is important because some of the screening cards, particularly those used in corporate hospitals who may import them from foreign nations, may also express the TSH in MIU per ml of whole blood units. So the clinician who's interpreting the cards must be aware of the conversion factors between the whole blood and the serum units. So a cutoff of 20 MIU per ml of whole blood units is equivalent to 40 MIU per ml of serum units. Generally in India on the card test, it's the serum units that is used more often. And for confirmatory venous sampling universally across India, it is serum units that are used and expressed in. So the upper limit of TSH between the first 24th and 48th hour of life, in case someone has had to screen the baby early because an early discharge is planned, or either due to insurance compulsions or due to lack of beds, as it often happens in the medical school, a higher cutoff of 34 MIU per ml of serum units must be used. So please understand, screening must be done after 48 hours if feasible, if not a cord blood sample only for thyroid, primary congenital hypothyroidism. In case you've had to collect earlier, use a higher cutoff, but do not collect the sample in the first 24 hours of life under any pretext. A repeat screen is almost always indicated between the second and sixth week in babies who are born low birth weight, those or very low birth weight, those in sick term babies in the NICU, preterms, and twins, particularly those of the same sex. This is because this set of neonates have an entity called the delayed rise of TSH, which might be missed on the initial screen, and hence it's always recommended to screen this set of neonates once again between the second and sixth week of life. Now, this is probably the most important part of the presentation, the screening algorithm. And I've attempted to simplify the algorithm provided by the Indian Society of Pediatric and Adolescent Endocrinology. The simplified algorithm goes this way. If your TSH in the first 2 weeks of life, when appropriately collected, is less than 20, you would pass this baby as normal and one which does not have primary congenital hypothyroidism. However, if the baby belongs to a repeat screen cohort, that is low birth weight, very low birth weight, sick baby in the NICU, or a preterm baby, you would call this baby back for a repeat screen anywhere between the second and sixth week. Now, if the TSH is greater than 20 on the screen sample, you are going to stratify the same into babies having TSH between 20 to 40, for whom you would call them for a confirmatory venous sample testing anytime between the 7th and 10th day of life, versus those who have a TSH of greater than 40, where you would call them back for confirmatory venous sample testing immediately. When you perform the confirmatory venous sample testing, please understand you would want to perform a free thyroid hormone level along with your TSH, which would help you then delineate the plan of follow-up and management. If on confirmatory testing, you find that the TSH has dropped to below 20 in the first 2 weeks of life or less than 10 after the second week of life, with a normal free T4 level, you will deem this baby to be normal and not initiate thyroxine. Whereas if on confirmatory testing, if the baby has a TSH of more than 20 in the first 2 weeks of life or a TSH value greater than 10 beyond the second week of life with a free T4 value of less than 1.1, this baby would be diagnosed with congenital primary hypothyroidism and would merit treatment with thyroxine at the earliest. Now, the third group is when you have a TSH which breaches the upper thresholds of normalcy, but the free T4 levels are well compensated. What do you do in such scenarios? And this group is quite a common one in clinical practice. The recommendation is to repeat the TSH in 2 weeks' time. So if your TSH remains beyond 10 at the third week of life or beyond, you would definitely initiate treatment in these babies. These babies are likely to have the milder forms of congenital hypothyroidism. Now, while the society says TSHs of less than 10 could be passed off as normal, it is important to discuss values of TSH between 6 and 10 with your pediatric endocrinologist, because this group could often have neonates with occult forms of congenital hypothyroidism. So I've circled that group for clinicians to understand that while the guidelines are meant for masses, The clinician must exercise individual discretion while dealing with his or her patients. When TSH values are less than 10 but more than 6, it is best to discuss these cases with your pediatric endocrinologist to understand that whether waiting and watching would be the right way ahead, or would you want to screen these babies with an ultrasound or a thyroid nuclear scan, or should you start thyroxine while counseling the parents that you may need to come off it at 3 years of age and perform an assessment of permanency test. So dysgenesis and ectopia constitute nearly 85% cases of permanent congenital hypothyroidism, whereas dysharmonogenesis globally contributes to nearly 15%. In countries like ours and others in Southeast Asia and the Middle East, where consanguinity and small community breeding is common, patients with dysharmonogenesis are much higher. So our percentages here hover around 22 to 24% compared to the global numerical of 15%. Pediatricians must be aware of the entity of transient congenital hypothyroidism, where treatment of thyroxine is important in early part of infancy, and then the baby is able to come off thyroxine when the time is right. We must almost always evaluate babies with congenital hypothyroidism of either form for associated congenital malformations and must not miss the condition being a part of a more complex genetic syndrome. Now, it's a very crowded slide. There are only two things that I'd like you to focus on, and that is the group which I spoke about with a normal free T4 but increased TSH. This is the group where the guideline recommends that clinicians can wait for a couple of weeks and call the baby for a repeat testing and not be in a hurry to start thyroxine. What does this group constitute? This group constitutes babies with transient congenital hypothyroidism or the milder forms of permanent congenital hypothyroidism. This group also constitutes babies who have delayed maturation of the feedback mechanism of the hypothalamo-pituitary thyroid axis. So it's just immaturity of the axis, which may not always merit treatment if the free T4 level is well compensated. This group includes babies with thyroid hormone resistance and babies with Down syndrome or other genetic syndromes. Now, these two conditions eventually merit treatment. The latter two conditions eventually merit treatment with thyroxine, and the clinical features are very obvious. It's the first two where observation for a couple of weeks, if the free T4 level is well compensated, is recommended. Now, coming to the group of transient hypothyroidism, as I mentioned, these are babies who would often have a normal free T4 value on confirmatory testing, but increased TSH on the screen and the confirmatory venous sample. These babies have a likelihood of coming off the thyroxine initiated in infancy, and hence the prognosis of the case changes, and the counseling that needs to be done to the parents naturally changes as well. So this group constitutes those babies who are born to mothers with Graves' disease, where the transplacental transfer of maternal antibodies and drug both is possible, leading to a transient functional hypothyroid state. These babies must be started on thyroxine, and as the effect of the transplacental antibody or the antithyroid drug wanes off, these babies are able to be weaned off the thyroxine. The rarer genetic conditions of heterozygous mutations in thyroid oxidase 2 deficiency or mutations in the TSH receptor also often present with transient hypothyroidism. Please note, I've said heterozygous mutations in thyroid oxidase 2. If the mutations are homozygous, the condition is often almost permanent. Patients being born in endemic iodine deficiency zones or those having prenatal and or postnatal exposure to higher quantum of iodides, like in the NICU, frequent scrubbing with povidone iodine, may often cause a transient hypothyroid state. Now, this is how, before I move to it, we need to understand that to make a diagnosis, or you need the screening algorithm and confirmatory venous sample testing. But to stratify the etiology, you would use either sonologic imaging and or a nuclear scan to complement your thought. So ultrasounds in the neonatal period must be performed by a trained neonatal sonologist with expertise in this condition. Nuclear imaging may not always be available across the country and the state, but offers the advantage that it is observer independent. You may not have an experienced neonatal sonologist, but if you have access to the gamma camera and the radioactive tracer, the technetium radioactive tracer, you can almost always affirmatively ascertain the diagnosis. This is just to give the audience a glimpse about how the representative nuclear images look like. This is how the thyroid gland in normalcy looks. This is how when the uptake is increased. Now, please understand the radioactive tracer uptake is compared to the uptake in the adjoining normal salivary glands, and a ratio is derived. Whenever the ratio is more than 1.5 times that of normal, the gland is perceived to have an increased uptake of the tracer, which is often associated with thyroid dyshormonogenesis. So if there is an enzymatic block, the gland is overworking, takes up the tracer avidly, and illuminates on the gamma camera. This is suggestive of thyroid dyshormonogenesis. Now, whereas if the tracer is decreased in intensity, it is often a sign of thyroid dysgenesis, that the anatomic integrity of the gland is compromised. Now, here you can see there is almost no tracer seen in the neck region. This is thyroid agenesis. Whereas in the last one, you can see that the tracer has accumulated not in the usual thyroid bed in the neck, but in the suprahyoid or a little further above in the lingual bed. So you can see this is representative of ectopic thyroid condition. These are representative images, and these often assist and are complementary to the views of an experienced neonatal sonologist. And what happens typically in dysgenesis is the sonologist would say that he's not able to appreciate thyroid tissue. The baby would often cry. He would mention that the scan is probably of a poor quality or a poor resolution because of excessive movement. But he says, I couldn't visualize thyroid tissue in the neck in athyrosis, or the thyroid looks hypoplastic in dysgenesis. Whereas the nuclear scan would complement the report, and the report would be issued saying there is either no uptake of the tracer in the thyroid bed or the uptake is reduced. What happens in dyshormonogenesis is the opposite. The sonologist would report that the gland is looking enlarged or goitrous. This is because the gland is attempting to overwork to compensate or obviate the enzymatic block. And similarly, a higher amount of tracer is taken up by the gland on nuclear testing. The only two exceptions to this concordance is what I have highlighted in this slide, is the first step of sodium iodide cotransporter defect in dyshormonogenesis, where there is presence of goiter clinically and on the ultrasound, but the gland does not depict any tracer uptake on the nuclear scan. This is because the first step of thyroid hormone synthesis is blocked, is defective because of the mutation in the sodium iodide cotransporter. So there is often a discrepancy between the nuclear medicine department and the radiology when one is dealing with this condition. The other entity which behaves similarly is where the baby has been exposed to iodine acutely, either peri or postnatally. So the ultrasound will document a normal gland in situ, but because of the excess iodide exposure, or what is called as the Wolff-Chaikoff effect in endocrinology, there would be no uptake of the tracer in the thyroid bed on the nuclear scan. So these are the only two conditions where you would see discordance, whereas everywhere else, dysgenesis would be associated with reduced uptake and reduced visibility, whereas dishormonogenesis would be associated with increased uptake and increased visibility. So one very important message is while etiologic stratification is important and helps us prognosticate the condition and counsel the parents very, very appropriately, treatment must never be delayed for the want of a nuclear scan. There are many cities in our country where nuclear scan may not be available, and the pediatrician is very, very justified in initiating treatment to these babies who merit or deserve it and not wait for the scan. Also, the scan should not be performed once thyroxine has been initiated for a week or more, because thyroxine itself blocks the uptake of the tracer, whereas the ultrasound could be performed at any point of time when feasible. So once the diagnosis is made and confirmed, how do we treat these babies? The dictum is to treat them with thyroxine as soon as possible. Usual recommended doses since the time we trained have always been mentioned to be 10 to 15 microgram per kg per day. Though now in the current era, we realize that the dose is based on the severity of the presentation, the etiology of the condition, and is often best individualized. My pediatric endocrinologist colleagues would agree with me that often doses varying between 5 to 8 microgram per kg per day suffice when there are structured screening programs in place, and as most of the cases are not very severe. The goal is to optimize the free thyroxine level in the upper half of normal range, which is the median and plus 2 ST in the first 2 weeks, and attempt normalization of the TSH in the first month or month and a half. So your first blood test after initiation of thyroxine must be in 2 weeks, and you must not attempt to normalize the TSH so soon, but only attempt to normalize the free T4 level in the first 2 weeks and allow 4 to 6 weeks for the TSH to normalize or optimize by the feedback mechanism. It is needless to say that treatment should be initiated as soon as possible and not later than 2 weeks after birth or immediately after confirmatory testing when the condition is detected by a routine screening test. The tablets are crushed and administered via a small spoon in a few ml of water or breast milk, and it is very important to tell the parent to rinse the spoon again with the same either water or breast milk to ensure that no part of the tablet has been left behind and stuck to the same. Yes, so how do you monitor these babies biochemically? The first test is at 2 weeks, which is your free T4 level. TSH is looked at a month and a half. In the first 6 months, you would screen these babies every couple of months or 8 weeks. And once the baby is at least 6 months old, until the third birthday, you would test these babies every 3 months. After 3 years, you could liberalize the testing to once in 6 months. The caveat here is whenever you have made a change in the dose of thyroxine, both free T4 and TSH should be checked after 6 or a maximum of 8 weeks to assess the adequacy of the dose change that you have made. Now, babies in whom you could not perform a detailed diagnostic assessment either because they presented to you late and you wanted to treat them in their best interest, or if the infant belonged to the high-risk cohort, you can always assess them at 3 years by an assessment of permanency. It can be attempted earlier if you have frequent suppression of TSH on very low or sub-threshold doses of thyroxine, but not otherwise. Very, very importantly, subsequent cognitive follow-ups. Now, in the Western world and in metropolitan India, maybe not all, but quite a few cities, the challenge is not dealing with gross intellectual disability or mental retardation. If structured screening programs are in place, the psychomotor development is grossly usually normal. But what remains to be understood better or dealt with are subtle specific memory deficits, attention and information processing defects like hyperactivity or arithmetic difficulties, response time, left-right hand coordination, driving, fine motor functions like gripping the pen or the paintbrush, very low decibel hearing and speech defects, and behavioral deviations. So this is the subgroup that is often encountered even in babies who are detected and treated timely, letting us know that there are factors beyond timely treatment which are associated with this condition which need to be better understood. Those babies who have syndromic forms of congenital hypothyroidism or have transcription factor mutations which are expressed both in the thyroid gland and other vital organs of the body like the brain, heart, lung, obviously have different prognosis, and in spite of timely detection and treatment, one may not often encounter very good long-term outcomes. But that group is very, very, very sparse. So the last, or maybe the second last slide that I'm going to speak on is a bit on genetics. This is what we do in our unit, a lot of it. We like to stratify clinically whether the congenital primary hypothyroidism is isolated or is it a part of a genetic syndrome or a syndromic constellation which is yet needed to be understood. Amongst the isolated group, which is the commonest, which constitutes more than 98%, in dysgenesis, mutations are identified only in up to 12 to 15% of the cases. So you could say that almost 85% of thyroid dysgenesis is either sporadic or is driven by genetic and or epigenetic mechanisms which are not well understood till date. The two of clinical interest for us are mutations in the TSH receptor and mutation in the PAX8 gene. This is in the isolated thyroid dysgenesis group. Now coming to dyshormonogenesis, which accounts for nearly a fourth of these cases in our country, 3/4 of them are dysgenesis and ectopia, where genetic mutations are less often found. In dyshormonogenesis, 88% of these cases often have underlying gene mutations, the common ones being in the thyroid peroxidase gene, thyroglobulin gene, dual oxygenase gene, and the sodium iodide cotransporter, as I mentioned. Now, coming to the lesser common group, the syndromic congenital hypothyroidism, these are babies who would have another manifestation in addition to the congenital hypothyroidism. And amongst the dyshormonogenesis group, pendrin gene mutation is the commonest one, which is often taught from the undergraduate days, where there is a goiter and deafness, and the mutation in pendrin gene is often present, leading to the diagnostic confirmation. The dysgenetic forms of syndromic congenital hypothyroidism include the NKX group of genes, which are associated with brain-lung-heart syndrome, PAX8 gene mutations, which are associated with renal and genitourinary abnormalities, and FOXE1 gene mutations, which are associated with midline defects and spiky hair. So this was just to emphasize to the audience that a lot of dyshormonogenesis, almost all, would have an underlying genetic mutation which needs to be looked for, whereas most of the thyroid dysgenesis is yet believed to be sporadic in origin. The last slide before I conclude, but very, very important, especially keeping into account that this is the woman's wing presentation, and as pediatricians and neonatologists, we also are a part of perinatal medicine, is how to detect and manage fetal hypothyroidism. So beginning with preventive modalities, adequate iodine intake should be ensured for all pregnant women. In our country, all pregnant women must get 250 micrograms of iodine every day, which is usually feasible through common salt usage. For women with a personal or family history of thyroid disease, thyroid hormone concentrations and TSH should be determined before, at the start, and during pregnancy. If pregnant women are on thyroxine, care should be taken to ensure an appropriate increase as the physiologic demands are higher. And in the first 12 weeks, the fetus secretes all of the thyroxine from the mother. And where does the role of the pediatric endocrinologist come in is between the 22nd and 32nd week of gestation, fetal thyroid diameter and circumferences must be measured. And if they are found to be above the 95th percentile for gestational age, a fetal goiter should be suspected. So there are gestation-specific charts available for fetal thyroid diameter and circumference. Now, if a fetal goiter is documented, chordocentesis and estimation of fetal serum TSH and free T4 concentrations are suggested. Please understand this is chordocentesis and not amniocentesis to make a diagnosis, whereas instillation of the levothyroxine is done into the amniotic fluid if severe hypothyroidism is diagnosed and progressive hydramnios is noted. So to sum up and conclude, the take-home messages for my colleagues here are universal screening for congenital hypothyroidism, at least primary, if not secondary and tertiary, is the essential right of every neonate and not a luxury. Appropriate timing of collection of the screening sample, the analytical parameters to be tested and cutoffs are very well defined in current literature and experience. Approaches to assess the cause and severity are important, but must not delay initiation of treatment under any pretext. Immediate initiation of appropriate thyroxine supplementation, periodic monitoring not just of the thyroid functions, but also regular assessment of developmental and neurosensory functions constitute essential contemporary standard of care. Thank you very much for the patient hearing.
Thank you so much, Dr. Abhishek. That was a wonderful presentation. It was quite brief but exhaustive, and you taught us about many finer nuances about how to diagnose and treat congenital hypothyroidism. Thank you so much for the presentation. We will be taking the questions at the end of the session after the second talk. If you could stop sharing your slides.
Yeah, I'll do that.
Yeah. So now I would like to invite the second speaker we have for today, Dr. Ganesh. Dr. Ganesh has done his MD Pediatrics from the prestigious GMC Mumbai. He's done his postdoctoral certificate from the prestigious SG PGIMS in Lucknow. He is a principal consultant at Max Healthcare, Saket and Gurugram. He's been the past secretary of ISPAE. He has 23 indexed publications and book chapters. He's been the co-author on hypoglycemia guidelines, and he's been on the editorial committee member for congenital hypothyroidism guidelines by ISPAE. I would also like to add that Dr. Ganesh has been my mentor, and he's taught me the P of pediatrics when we were together in Grand Medical College. So more than him, I'm delighted to have him today on this platform and share the screen with him. Thank you so much for accepting our invitation, Dr. Ganesh, and over to you. So I will be talking about Precocious Puberty Academic Pulse.
Thank you very much, Amog, for inviting me. Thank you, Maha IAP. I think IAP would be the place where I can pronounce my name as Jevlikar rather than Jevlikar, which I am also getting used to staying 16 years in Delhi NCR. I come from Latur in Maharashtra and now residing in Delhi NCR for the last 16 years. I know that we are all in a somber mood today, but I think carrying on with our daily routine is the best that we can do presently. I'm going to talk about approach to precocious puberty, and we'll be discussing briefly about physiology of puberty. I don't want to bore you with a lot of details of physiology. We'll be learning what is important for today's talk. Then we'll go through definition and etiology of sexual precocity and some basic aspects of clinical evaluation. I think we will take help of few illustrative cases to understand various aspects related to precocious puberty. I know that in 20 or 30 minutes, it may not be possible to cover each and every aspect. I will try and focus on things which are important for a practicing pediatrician and not go into details of therapy or details of peripheral precocious puberty, which is a little less common entity. We know that puberty is a stage of development during which secondary sexual characteristics appear. And there is transition from sexually immature to sexually mature stage. But this is not the only thing that is happening in puberty. Along with the secondary sexual characteristics, there is a somatic growth. There is a growth spurt that happens. Then there are changes in body composition. There is bone mineral accrual. Puberty is the time when we accrue the bones, bone mineral, one of the maximum during the postnatal period. There are changes in behavior, as many of you are parents of pubertal children, and you would know by self-experience also, in addition to Nelson textbook. There are changes in sleep patterns. So actually there are changes in the sleep timings and the duration of sleep that is required during adolescence. Now, with regards to today's topic, just taking you back to anatomy and physiology, that everything is controlled by the super boss, that is hypothalamus, which secretes what is called as GnRH, that is gonadotropin releasing hormone. So this boss instructs the subordinate, that is pituitary, gonadotroph cells to produce FSH and LH. And like a manager, pituitary subsequently orders the gonad to produce the sex steroid, which is predominant sex steroid being estradiol in girls and testosterone in boys. The sex steroid, in addition, has a negative feedback on the pituitary gonadotrope as well as the GnRH secreting neurons. So like many other hormones, this feedback loop system is what keeps the homeostasis in check. Now, this HPG axis is not only active during puberty, but is active at a couple of times in our life. In fetal life, it is important, especially in male infants, for production of testosterone, formation of penis, fusion of scrotum, etc. So it is active during fetal life. Then towards the late gestation, it becomes quiet. And during the first, immediately after birth, after a few hours of birth, there is again activation of this HPG axis, and this axis remains active in the first 6 months. We do not completely know the total significance of this particular activation in the first 6 months, but it may have implications on several things we will see in the subsequent presentation. Then it undergoes what is called as juvenile pause, which is mediated by inhibitory neurotransmitters such as GABA. And when the time is ripe, there are signals in the body, and which lead to activation of the HPG axis, initially characterized by pulses of GnRH, followed by FSH and LH, initially in the night and subsequently in the daytime. And this process is very, very important for a natural progression of puberty. So there is a slow and sustained exposure to estrogen, which leads to breast development in girls, and testicular enlargement and testosterone production, which leads to changes in boys. There have been a lot of addition to the knowledge of how the puberty exactly triggers. We are not going into exactly all the details of this, but there are two important genes that need to be remembered. One is a KIS1 neuron, which produces a hormone, which produces a substance called as kispeptin, which interacts with its receptor called as GPR54 receptor. And this is supposed to be one of the important trigger for the puberty. And there is another gene which has been, I would say, discovered fairly recently, MKRN3, which basically works like a brake on the puberty. So when the brake is released, and when the MKRN is it allows the puberty to happen. So this also has been identified as an important gene contributing to pathological causes of precocious puberty. Timing of puberty, when anybody goes in puberty, has a very strong genetic influence. And it is not necessary that a daughter is influenced by the mother and the son is influenced by the father. It could be either ways. There are nutritional factors and other hormonal signals that are important, particularly obesity, leptin, and insulin. These hormones kind of play a permissive or positive, triggering kind of a role for puberty, whereas ghrelin works in an opposite way. And there are environmental factors, especially the role of pollution and plastic exposure, bisophenols, phthalates, insecticides, etc., is under extensive research about how it influences the pubertal timing. There have been secular trends in the onset of puberty, especially breast development. We do see menarche also happening a bit earlier, but the decline in the age of breast development is well documented across several countries as the socioeconomic health of the society improves. This is the data from the Indian population from north in Delhi, about 2,000 girls from 6 schools. And it was observed that the median age of thelarche was about 10.8 and median age of menarche in urban girls is about 12.4. In rural population, the menarche happens a bit later. And in this study, it was shown that overweight or obese girls have earlier onset of thelarche and menarche. So obesity, interestingly or curiously, triggers puberty in girls, whereas in boys, we do not see that kind of an impact of obesity. So when do we say that puberty is precocious? The definition is largely statistical, like many other conditions, where we say that if the average is this, average is a particular age, 2 standard deviation below that is early, 2 standard deviation above that is late. So this is pubertal onset before 8 years in girls and before 9 years in boys is considered as early puberty. This is largely derived from very old studies in UK by Tanner, Marshall and Tanner, and they hold true even till date. There have been some suggestions as to decreasing this definition especially for African population, but there is a fear that if we reduce if we decrease the age cutoff for the onset of precocious puberty, we may miss out on some pathological causes of precocious puberty. Usually breast development in girls and testicular enlargement, that is testicular volume more than 3 ml, is the first sign of puberty in boys and girls respectively. Now, it is important to understand a condition called as premature adrenarche, which is not exactly a precocious puberty leading to menses, but an early activation of the adrenal androgen, that is zona reticularis, which leads to onset of pubic or axillary hairs before 8 years in girls and before 9 years in boys. And sometimes we do come across premature menarche, where the onset of menses has happened before 9.5 years of age. This may be because the breast development was missed altogether and the girl straight away presents with menarche. That is not uncommon in our practice. Or sometimes it can be because of some other conditions where there can be a little breast development and directly the menses or PV spotting happening. What are the concerns when we are dealing with a girl with precocity or a boy with precocity? First and foremost, as a physician, we need to understand that precocious puberty may not be a disease by itself, but it can be a presentation of an underlying disease. So it can be a presentation, for example, of a germinoma or another neoplasm intracranially. Or it could be sequelae of some perinatal toxoplasmosis or tuberculosis or something like that. It could be a presentation of congenital adrenal hyperplasia. Other than this, there are concerns about what would be the adult height. The height loss is likely to happen with younger is the age of onset, more is the chance of height loss. So supposing if the breast development has started before, let us say 6.5 years of age, the girl could lose as much as 15 centimeters of height. Whereas if it has started about before 8 years of age, there could be loss of 6 to 10 centimeters of height. As we go beyond 8, this becomes almost like a gray zone where we have to debate and discuss whether treatment is really required or not. Then timing of menarche, if it is very early compared to the peers, it could be distressing for the child and for the family. And there could be engagement in romantic or sexual relationships comparatively earlier, which is also which could be a matter of concern sometimes. There are some epidemiological associations with early menopause or risk of breast cancer because of early exposure to estrogen, breast cancer being estrogen dependent cancer. A causality has not been totally proven, but this is something which is seen in epidemiological association. For the convenience of clinical description, puberty is divided into Tanner stages. from stage 1 to stage 5, stage 1 being totally prepubertal and stage 5 being totally adult stage. It is useful to have a description of these images or nearby your bed, at your table, so that you can refer to it as and when required. Here, it is important to remember that the girls grow maximum when the breast development is just happening. And this is often missed either by the parents and sometimes even by the physicians, that the breast development, when it is happening, that is the best time for us to evaluate and intervene. Whereas boys grow towards the later part of their puberty, like stage 3 or stage 4. They have a peak growth velocity in the later part of their puberty. Therefore, if you see boys of 5th or 6th, children of 5th or 6th grade, like 10, 11-year-old, the girls would be taller and the boys would not be, will be comparatively shorter. So if you get any child complaining that the girls of my class are taller and the child is in this age group, you can just counsel them that your time will come. Now, broadly, the types of precocity are divided based on from where these hormones are coming. So if the sex steroid is coming by a premature activation of the same process that was otherwise happening, like activation of hypothalamus leading to FSH-LH and then sex steroid, the same sequence happening, but happening prematurely or happening too fast, that is called as central or true precocious puberty. So understandably, the changes of sequence, the sequence of changes will be similar to otherwise normal puberty, but the tempo of progression may be variable. It will be always isosexual. That means the changes will be corresponding to the biological sex. Whereas if this sex steroid exposure is happening either from outside of the body or from within the body, but independent of the hypothalamus and pituitary, which means that the gonad is becoming autonomous and producing the sex steroid on its own, either because of some congenital anomalies or because of some tumors. That is called as peripheral or pseudo precocious puberty. Here, understandably, the hormone exposure can be of either sex. So therefore, a girl could virilize or feminize, either ways. So the changes can be isosexual or heterosexual. In addition to these two broad categories, there are other types of precocity also, which we will learn in the subsequent slides. Now, central precocity in girls is 15 to 20 times more common than boys. But in majority of them, we do not find an underlying disorder. So 80 to 90% of girls have what is called as idiopathic central precocious puberty. And neurological disorders, which are much more commonly discovered in boys, in about 30 to 50% of boys, and in about 10 to 15% of girls. It could be prior radiation exposure. This is particularly common in leukemia or optic glioma kind of patients. Intracranial tumors, most notoriously hypothalamic hamartoma. Past CNS infection, tuberculomeningitis, congenital toxoplasmosis, etc. And then genetic. Now here, just want to again highlight about MKRN3 gene, which has been documented to be responsible for about 20 to 30% cases of familial central precocious puberty. Interestingly, children adopted internationally as well as domestically, they may have earlier onset of puberty. This is probably linked to their early period of malnutrition, followed by a very good nutrition leading to a very rapid catch-up growth and obesity. Every single condition that causes peripheral precocious puberty can go on to trigger the central precocious puberty. So CAH, Leydig cell tumor, all these conditions can subsequently trigger central precocious puberty. Peripheral precocious puberty, as I said, could happen because of exogenous steroid exposure. This can happen because of like the OCPs of the mother being consumed by the child, or testosterone cream being exposed, being used by the child accidentally, or sometimes some of the supplements, etc., could cause these things. In girls, peripheral precocity could result from hypothyroidism, ovarian cyst, or McCune-Albright syndrome. And a heterosexual peripheral precocity could result from CAH. Whereas in boys, CAH is the most common cause of peripheral precocious puberty. Other conditions being HCG secreting tumor, an interesting condition called as testotoxicosis, which is a LH receptor germline mutation, And not mentioned here, but Leydig cell tumors is also one common cause of peripheral precocity in boys. These other conditions that I was mentioning about do not fall clearly in the central or peripheral precocious puberty, but somewhere along the spectrum. This include isolated premature thylarchy, premature adrenarchy, isolated premature menarche, and isolated scrotal or labial hairs of infancy. In these conditions also, endocrine referral may be needed to rule out pathological conditions because there can be overlapping clinical and biochemical presentation. In terms of evaluation, important points in the history include noting the correct date of birth. It is amazingly common to have a wrong date of birth in India, even in documents such as Aadhaar card. So please be very careful in asking for the correct date of birth. Family history, especially with respect to pubertal timing, not just on one of the parents, but from the both parents. Birth weight is important because girls born with low birth weight, or SGA girls, have earlier history. I mean, they have higher incidence of premature adrenarche as well as sometimes premature or precocious puberty. Careful history of neurological symptoms. Again, asking for exogenous exposure sounds very easy to hear, but sometimes it can be very tricky to ask. And the ODP of growth and pubertal changes. On examination, charting of the height and weight on a growth chart with whatever available readings is extremely important. Cannot be, I mean, I would re-emphasize the importance of maintaining a growth chart. We should get used to doing Tanner staging and testicular volume. Unfortunately, at least during my pediatric training, this was not a usual thing that we were doing. But this is very, very important and should be, as now we are uniformly seeing adolescents too. Inspecting vaginal mucosa, estrogenized mucosa appears pale pink and there may be secretions. Examination of fundus, goiter, careful examination of catheolar spot, and this sometimes requires complete exposure. It goes without saying that there has to be an accompanying chaperone when you're examining the child. In terms of investigations, an important investigation is bone age. And then we do baseline gonadotropins, FSH, LH, and estradiol or testosterone. The sex steroids have to be estimated at 8 o'clock in the morning. Sometimes we need what is called a stimulation tests. We'll discuss in the cases, during the cases. For girls, we do ultrasound of pelvis and we look at the uterine length, ovarian volume, endometrial thickness. And if we have proven central precocious puberty in all girls below 6 years of age, or where the changes started before 6 years of age, and in all boys, irrespective of when the changes started, the MRI of sella should be done. Please do not write MRI brain because MRI sella requires specific cuts. So it is very important to specify MRI sella or pituitary and hypothalamus if you like. Palpation of breast is also an important technique. This should be done. This is important, especially in obese girls, because lipomestia or fat can be confused with the breast tissue. So if we squeeze the tissue between the thumb and forefinger on the side of the areola in a sitting patient, typically the breast is felt as a rubbery kind of or a round circular rubbery kind of a material underneath the nipple and areola. Whereas if it is just fat, you will be able to approximate your thumb and finger completely. Testicular examination provides valuable clues. I'm sorry, the X-ray is misplaced here. The testicular examination is done with the help of an orchidometer, which is available at fairly cheap rates from the ISPE website. So in this picture, you can see that there is a symmetrical enlargement of testis. So if there's a symmetrical enlargement of testis in a boy with precocity, it indicates central precocious puberty. And in this image, you can't even see the other testis. There is only a right-sided testicular enlargement. So asymmetrical testicular enlargement is a clue to the presence of Leydig cell tumor. If you have an enlargement of phallus, but the testes are not enlarged, testes are very small, prepubertal, that is likely to be indicating peripheral precocious puberty. There are some conditions listed amongst peripheral precocity, which could cause a slight enlargement of testis, but the other changes of puberty are disproportionate to that. So, which means that the penis may be of stage 4, but the testis may be just 5 or 6 ml. So, in HCG secreting tumors or testotoxicosis, this can be seen that the testes are slightly large, but the changes of puberty are much more advanced compared to the size of testis. Now, when we talk of bone age, it is often we see these kind of X-rays being advised where only wrist is visible, and that is not what is recommended. Okay, so don't write X-ray of the wrist, write X-ray of the wrist as well as hand. So wrist plus hand, or hand, if I mean, depending, please speak to your radiologist how they would like to you to place the order. But what should be visible is the ends of radius ulna, all the carpals, all the phalanges, till the distal end of fingertips is what should be visible. So this is the correct X-ray to be ordered. In progressive precocious puberty, the bone age will be advanced by more than 2 standard deviation, which could be, I mean, the standard deviations are different for younger and older children. So if, for example, in older child, up to 1.5 year of bone age plus minus the chronological age can be normal. Whereas in a younger child, like an infant or 2-year-old child, even a 6-month advancement or 1 year advancement may be significant. We commonly see bone age reports like this where the range is very broad, 9 to 16, or a very vague kind of a range given by radiologist. Or sometimes we are used to kind of counting the carpal bones and naming the bone age. Both of these are wrong practices. The bone age can be estimated by several methods. The easiest is if you have a bone expert software in your hospital, which processes the X-rays and gives you automated bone age estimation. Or if you don't have this, you could use applications which can help you to derive the bone age using the Tanner-Whitehouse method. Or you could have those who are old timers and they want to have hard books, then you could have copies of Tanner-Whitehouse Atlas or Grulich-Pyle or Gilsans-Ratib Atlas. The Gilsans-Ratib one is quite freely available on internet. And you could use either any of these methods. Any of these methods will be better than going by such kind of reports or guesstimating rather, the bone age by carpals, etc. Let's go through few cases to understand these things more clearly. Now, this is a case who I saw just probably after the pandemic, 9-year-old girl who presented with menarche. She had noted, like many other children, she gained weight during the COVID pandemic, and the breast development was noted at 7 years of age. And she did discuss this with the doctor, but she was told that it's fairly common nowadays and she doesn't need to do anything. So she comes with menses at 9. She was very distressed. But at this point, her bone age was already 13 and a half. Now, intervention at this point may help delaying the menses or stopping the menses, but it is unlikely to be of any help with respect to height. So therefore, timely referral is very, very important. And the correct time of referring a girl with precocity is when the breast development is noted before 8 years of age. At that time itself, do not wait till the menses happen. Another common scenario, 1-year girl with breast development. You can see clear-cut breast development, no other changes. The anthropometric parameters are appropriate for age, bone age is not advanced, and the hormones are also not indicative of pubertal onset. So this is a common scenario. This condition is called as isolated premature thelarchy. Evaluation is important because some of them could be presentations of central precocious puberty. But after the baseline evaluation, one can just follow them up every 3 monthly and note that the changes are regressing. In most girls, these breast development regresses by about 2.5 to 3 years of age. But if the changes are progressive, or if you're noticing other changes, or if the growth velocity is abnormal for the age, then you need to evaluate further and treat if necessary, because about 10 to 15% of these girls could go on to have progressive central precocious puberty. Third case, 5-year, 8-month girl with breast development, just beginning, no evidence of neurological disease clinically. Her bone age is advanced by about 1 year and 2 months, 1.5 years or so. And her hormone profile clearly indicates pubertal onset, LH of 2.43 and estradiol of 110 picogram per ml. The uterus is 4.7 centimeters. More than 4 centimeter clearly indicates estrogen exposure, and ovaries are 3 and 5 cc, which again more than 1.5 cc or 2 cc ovary indicate pubertal onset. So here the diagnosis is central precocious puberty. I'm sorry, there is some funny thing going on with the presentation with the growth chart being replaced with bone age atlas. I don't know what has happened. So diagnosis of central precocious puberty is done with the help of pubertal changes along with documenting the growth velocity, bone age being advanced more than 2 standard deviations. A basal LH, if you're using an ultrasensitive LH assay, basal LH of more than 0.3 is quite sensitive and specific to indicate the pubertal onset. But if you're not very sure about the quality of your tests, then I would say more than 0.6 or 1, these kind of more older or conservative cutoffs can be taken for basal LH to indicate the pubertal onset. If it is not clear using these parameters, then we need to do what is called as GnRH agonist stimulation test. Previously, it used to be GnRH stimulation test, but GnRH is no more available. So it is a GnRH agonist stimulation test. Here we use either triptorelin or leuprolide to do this test, and we check the LH hormone. After in the triptorelin test, we check it after 3 hours. And sometimes we check it after, like in the other test, leuprolide test, at 1 and 3 hours. So if the stimulated value, peak value is more than 5, it indicates onset of puberty. Now, if you have proven progressive central precocious puberty, it can be quite effectively treated with what is called as GnRH analogs. So these are basically agonists of the GnRH peptide that is produced within the hypothalamus. And they work by kind of competitive inhibition. They occupy the GnRH receptor sites for a long period of time, and they therefore inhibit the endogenous GnRH. The most commonly used ones are leuprolide and triptorelin. These are the commonly used ones in India. There are 4-weekly or 12-weekly formulations. In some countries, even 6-monthly formulations are available. They are indicated for progressive central precocious puberty. So if the breast if the clearly the changes of precocity are there and the changes are progressing, bone age is advanced, there is a likelihood of short adult height or adult height being below the mid-parental height. In these situations, these injections are indicated. There is a small group where the changes start but do not progress. That constitutes about 10 to 20% of girls, where the changes may start early, but they just do not progress. In those girls, giving the treatment may not be necessary. In special children, especially autism, ADHD, or some of the cerebral palsy kids, the parents may be very apprehensive about dealing with very early menses, and therefore we may delay the puberty by a year or 2 in those girls. And these treatments are also used for hormonal suppression in gender dysphoria. So if you have diagnosed an adolescent who has not yet reached the age where they could be started with cross-sex steroid therapy, we suppress their puberty using the GnRH analogs because they get this distress. If a girl who identifies herself as a boy gets distressed if there's a breast development or menses happening, and therefore GnRH analogs may be required to alleviate this distress. Side effects are mainly local. They include injection site-related pain, swelling, rarely sterile abscess formation. There are no permanent negative effects on subsequent menstruation, fertility, pregnancy, etc. Some studies do report association with weight gain or PCOS, but causality again, like whether it is linked to the treatment or whether it is linked to precocity, is not yet fully known. I'll rapidly run through some other cases. This is an 8-year, 9-month girl with PV bleed who presents with short stature. There are very few conditions which have short stature with precocious puberty. So you can see that there's hardly any breast development and she has had PV bleed directly. What's the likely cause? And the most likely cause in this situation is primary hypothyroidism. She also had large ovarian cysts which were releasing this estrogen, which was leading to slight breast development. But because it was intermittent estrogen exposure, it leads to intermittent PV bleeds. Here, the treatment is starting thyroxine, but the thyroxine doses have to be started, unlike in congenital hypothyroidism, the doses have to be started very gradually and the doses have to be increased slowly. So if you have a precocious puberty with short stature, it could be because of hypothyroidism or a concurrent growth hormone deficiency, which is a very common scenario in childhood cancer survivors. If you have menstrual bleed with little or no breast development, suspect hypothyroidism, ovarian cyst, exogenous estrogen exposure, or local conditions such as genital trauma, neoplasms, genital neoplasms, cervical neoplasms, etc. Next case, 7-year-old girl with axillary hairs, born low birth weight, no breast development, only pubic hairs are present and axillary hairs are present. There is no thelarchy. The BMI falls in obese range. So this condition is called as, the most common cause of this condition is premature adrenarche, which is commonly seen in SGA girls and also in obese girls. In this situation, we need to rule out other conditions like non-classic CAH or androgen secreting tumors, which could also present with similar kind of a presentation. Previously, it used to be thought as a benign condition, but now we know that girls with premature adrenarche have a high risk of developing PCOS. So therefore, diagnosis of premature adrenarche is an opportunity to introduce healthy dietary measures and lifestyle measures at this age itself. Case 5, a 6-month-old boy with pubic hairs, which largely actually were more than pubic hairs, they were more on the scrotum. Testes prepubertal, no significant penile growth, otherwise normal clinical exam, bone age is also normal, hormone levels are normal. This condition is also fairly common. It's called as isolated scrotal hairs of infancy. The hair distribution, unlike in other cases of puberty, is predominantly scrotal. It only increases to a certain extent, and by 1.5 to 2 years of age, it's gone. If you diagnose this and then later on develop that the pubic area is also having hairs, the hairs are becoming darker, thicker, curlier, then please suspect your initial diagnosis and re-evaluate the child. On the other hand, this boy presented at 4 years of age with penile enlargement and pubic hairs and prepubertal kind of testis. As I said, small testis, other changes of puberty, it is likely to be peripheral precocious puberty. Accordingly, the LH-FSH is suppressed, testosterone is high. Look at the bone age. The bone age is advanced at least by 6-7 years. This is quite common in simple virilizing congenital adrenal hyperplasia, because salt esters would present with other abnormalities in the neonatal or infancy itself. So this was a case of 21-hydroxylase deficiency causing peripheral precocious puberty. He was started on treatment, and 3 months later, his 17-hydroxyprogesterone was well in control, but his testicular size is now increasing and testosterone is still high. This is happening because he has now got triggered into central precocious puberty, because once his steroid treatment was started and this inhibition by other androgens was taken off, his HPG axis has become active, and now this boy needs to be on GnRH analogs treatment in addition to his steroid treatment. I think last case, 9-year-old boy presents with inappropriate sexual behavior, masturbation, and a testicular volume of 10 to 12 ml. As I said, boy with precocity, symmetrically enlarged testis, likely to be central precocity. Bone age is clearly advanced, testosterone is very high, and the LH is consistent with the central precocious puberty. The dictum is that in a boy with precocity, we must do neuroimaging. And this child had a huge arachnoid cyst, which was causing this abnormality. So please, once again, remember that about half of boys with central precocity may have underlying neurological conditions. So to conclude, I would say that if you have pubertal changes before 8 years in girls and 9 years in boys, they are abnormal and they need to be evaluated. There are some benign forms which may not need to be treated, but they need to be followed up, because some of them could go on to have progressive forms of precocious puberty. Premature adrenarche is common in SGA girls. So this is something which should be informed to parents right in the infancy itself, the long-term sequelae of SGA. Precocity is much more common in girls compared to boys, but the boys have higher percentage of underlying pathology. Diagnosis is based on clinical assessment, bone age, hormonal studies, and imaging as clinically indicated. If we have borderline kind of results, we are not able to clearly decide whether it is to be treated or not. We tend to follow them up for 3 to 6 months to see the progression and the growth velocity. Central precocious puberty can safely be treated with long-acting GnRH analogs. They are safe and effective. They do not have negative impact on the subsequent reproductive capacity of the individual. Height benefits of this treatment are clear-cut if the thelarche has started before 6 years of age, and there are no or minimal benefits in height if the breast development has started beyond 8 years of age. Unfortunately, many a times the parents are not able to clearly remember when the breast development started, and therefore the decision may then depend on other parameters. Thank you very much for your patient hearing. I'm sorry for some of the slides being displayed in a very funny manner. Thank you.
Thank you so much, Dr. Ganesh. It was very elaborative. We went through to the physiology and we ended up beautifully with so many cases. I think it's been a wonderful evening of learning. Surprisingly, the chat box is quite silent. I guess most of the information has already been delivered by the speakers. But still, I have a few questions which I thought should be discussed on this forum. Dr. Abhishek, I had a question that there are some preterms in the NICU who are really septic or sick, who are not on any enteral or NG feeds. And if they have problems with their thyroid levels or TSH is higher on the higher side, so how do we administer thyroxine to them as a supplement?
So correctly, in preterms, in premature babies, the first sample should usually be taken between day 7 and 10. By the end of the first week is the time you take it in the NICU. And if you do make a diagnosis of hypothyroidism, now usually preterms would have a delayed rise in the TSH. If they're already depicting a rise, you know there is a problem. The caveat here being the free T4 levels that are looked at in preterm babies could be physiologically lower. Now, I didn't elaborate on that aspect because it would make the issue complex. But while TSH levels are similar, they're not similar in both term and preterm babies. The free T4 levels are physiologically lower. The entity is physiologic hypothyroxemia of prematurity. So you might not always want to treat a preterm if the biochemical profile is not suggestive of hypothyroidism. However, having said that, if the diagnosis of congenital hypothyroidism is made in a preemie, the modality of replacement still remains thyroxine enterally. So even in a baby who's not on feeds, the modality of replacement is enteral thyroxine. Intravenous levothyroxine is used sparingly and only for emergent situations. It is reserved only for emergent situations. And in routine situations, including in the NICU, enteral replacement is the norm.
Okay, okay.
But the important take-home message is when you're interpreting free T4 levels, gestation of the baby needs to be taken into account. What I have elaborated is assuming that the infant is a term infant.
Correct, correct. Okay, and Dr. Ganesh, I had a question for you as to how do you differentiate between thelarche in a child and lipomastia? Because especially after COVID, we get a lot of children with very high BMIs. So as a clinician, how do we, before we refer to the endocrinologist for further evaluation, how do we differentiate both these conditions?
Yeah, it's a very confusing sometimes to differentiate between fat and breast tissue. As I said, and it is more difficult in obese girls. I mean, in lean girls, it is easy to identify breast tissue from the contour itself on inspection. And on palpation, you can try and approximate your thumb and index finger on the side of the nipple. And when you try to approximate, you will find that between the two fingers, you can feel a ring of firm tissue underneath the nipple and areola, a concentric ring of a firm rubbery kind of a consistency, which may be also a bit tender to touch because the breast tissue or the glandular breast tissue is a bit tender to touch. Whereas in case of fat, it's just like the lipoma slipping sign. So you will be able to easily approximate your thumb and index finger. And having said that, there are situations where, despite of doing all these things, you may not be able to accurately identify. And in such cases, an ultrasound of the chest may be helpful.
Okay. I had one more question for Dr. Abhishek. After we start with the thyroxine treatment for a proven case of congenital hypothyroidism, when do you expect after initiation of treatment, when does the TSH level become normal?
Yeah, so in these situations, like I emphasized, the first goal is to normalize the free T4 level, because that is what is going to cross your blood-brain barrier and assist in the myelination, that too after deiodination to T3. So the first dictum or the first rule is to have adequate free T4, usually above the median towards the upper half of normalcy. And this must be achieved in 10 to 14 days after initiation of thyroxine. Normalization of TSH occurs by a logarithmic equation. So it's the feedback mechanism that once the free T4 begins to rise, there is a negative feedback suppression on the pituitary by it, leading to suppression of the TSH. So that usually takes anywhere between 3 to 6 weeks. And that is why the first TSH is usually done after a month, month and a half. But to ensure that the dose that we have provided is appropriate or is sufficient, we usually ask the baby to be pricked at day 10 or day 14 to understand the free T4 level.
Okay. Okay. And Dr. Ganesh, I would like you to throw some light on endocrine disruptors, which is the most common topic nowadays, because so many things are implicated in this, right from the substances in plastic containers to soy formulation. So if you could just enlighten us about it.
Yeah, I think, this is a huge area of interest as well as research, and some of these things are associated with earlier onset of breast development, especially bisphenol and phthalates. Unfortunately, we live an era where some of these things, we cannot even avoid exposure to some of these things. But I think overall, what I would say is that breastfeeding in the first 6 months, avoiding high intake of sugars, processed food, because clearly we know that obesity is a trigger for puberty. And there are some things which have to be really, balanced out. For example, some people just don't give milk. I don't see that there is enough evidence to link milk with precocity. But milk also has a lot of other benefits, such as providing a good quality calcium. So therefore, depriving children of milk may not be a evidence-backed decision. In terms of plastic exposure and insecticide exposure, it is like if we adopt environment-friendly practices, obviously it is better. But as I said, that exposure to these things may not be totally avoiding at this point, may not be in the clinician's hand or in the parent's hand also. So I think these requires a lot of interventions on a community or a political or a societal level.
So what about the hormones in milk? Like a lot of discussion is there about.
So largely, I think one of the hormone that is most misused in milk industry is oxytocin. But there's no evidence to link it with precocity. So it is largely, it becomes a fashion sometimes to stop milk or stop wheat, despite of not having any celiac disease or anything. So these things become like trends on Instagram or Facebook. And I think many of these things may not be actually backed by science. So what we need to actually do is probably collect more evidence before we kind of give a evidence-based answer to this question.
I guess it comes down to lifestyle modification at the end of the day.
But the only thing that is clearly known is, and we see it in practice, is sugar intake and refined carbs and anything that triggers obesity is also associated with precocity, and also in the gynecomastia in men. I see that quite commonly that obesity or high intake of sugars is also associated with exacerbation of pubertal gynecomastia.
And just one observation which I've seen as a clinician is we see a lot of children with neurodevelopmental disorders like ADHD who usually have precocious puberty. So, is there any specific correlation as to why it happens?
Since both of these things are originating from the neurological system, yes, there is a higher percentage of children that we see in on occurrence of puberty in girls with ADHD and autism. As I said, that we could prolong the puberty by giving treatment somewhat, but their bone health is also important. So we can't give this treatment for a very long period of time. So it has to be balanced out in consultation with a pediatric endocrinologist. What I would add is that there is this thing about, आजकल तो menses हो जाते हैं 8 साल में या 8.5 साल में या 9 साल में, and this sentence is heard not just in society but also sometimes some of the gynecologists or some of the pediatricians or physicians may give this sort of advice कि कुछ नहीं 8 साढ़े 8 में हो जाते हैं menses, पर 8 साढ़े 8 में menses in a normal girl होना आज की डेट में भी it is not normality. So I mean, I can agree that previously it used to happen at 12 and now it is happening at 11, 10 and a half. I mean, that there you would take a call based on everything else, but something happening at 8, 8.5, 9 definitely needs to be looked at.
It causes a lot of emotional repercussions for the family and the child as well, actually.
Not just emotional. Sometimes, I mean, some of these things could be medical. I mean, sometimes you could have a disease or underlying problem
Yes,
causing
yes.
this thing.
Correct. So, Dr. Sanjay, sir, you have any questions? Any questions for the experts?
Abhishek, do you think any lifestyle changes make differences? Do we think means it lifestyle changes has made means a little bit earlier of the more precocity?
Yes, definitely, sir. As Ganesh rightly highlighted, increase in adiposity and why, literature, published literature and clinical experience, both very categorically let us know that increased accumulation of adipose tissue and also the rate of change of adipose tissue peripubertally is linked to early onset of puberty. Also, India as a nation is going through the exaggerated secular trend now. What happened to the West 3 decades ago is happening in India. We are economically better. We are richer in calories. We are higher in adipose tissue. The mean age of onset of puberty and menarche, as Ganesh mentioned, is getting earlier. This is going to lead to a shorter generation of adults as it happened in the West 3 decades ago. And very rightly, what we need to emphasize to parents, teachers in schools and pediatricians is we need to understand the mean age of onset of thelarche in girls is around 10 years and 2 months. So 50% of our healthy girls will have or should have breast development at 10 years and 2 months. And the mean age of menarche in urban India, I'm talking of international schools, the data that we have collected across almost 17 international schools in Bombay is 12.5 even today, 12 and a half years even today. So you can look at a standard deviation. Within a standard deviation could be accepted as a deviation of the norm or accepted as an extreme outlier. But beyond that, we need to look into the reason. What is it? Is it lifestyle? Are these endocrine disruptors? Or is there an organic etiology within that needs to be looked at and treated? And as Dr. Ganesh mentioned, it's often girls come after the age of 8 years with breast development. We don't pass them off as normal. We look at the standard deviation between their existing height and the bone age, calculate the SDS. If it's large, we know even that is going to have an impact on their final height. Probably physiologic and definitely psychologic. So we look at statural benefits, we look at physiologic advantages, rule out an underlying organic etiology, look at the psychological implication, and then make a decision with regards to regulation of the pubertal process.
Dr. Ganesh, I had one more question. Like the long-term use of these topical steroids, can they also cause precocious puberty?
Now, topical steroids is a very broad entity, but if we are talking of topical glucocorticoids can cause growth suppression and obesity and exogenous Cushing's and adrenal suppression. but not per se precocious puberty. But if there are some preparations which may contain androgens or estrogens, and there one could have sometimes some cosmetics using excess of tea tree oil or lavender oil exposure can also cause precocious puberty in girls.
Okay, I think that has been a wonderful session of learning today. It's almost like 11:15. The time has just flown by. I thank both the speakers and the audience for a patient hearing, and I would invite Dr. Tanushree for the official vote of thanks.
Thank you.
Thank you. Thank you so much. It was just wonderful. It's 10:45, and as Omuk said, it still have almost 50 people still waiting. And thank you so much. I would like to thank the Maha-Happy platform, Dr. Sanjay Pakmore sir, Dr. Amol Pawar sir, Dr. Sanjay Deshmukh sir, and Jaya ma'am for giving us this fantastic Thursday thrills. And every week we have this continued learning and so many take home messages. So one of my teacher, he used to say it should be take to work message. You know, you if you go take it to home, so maybe you don't implement it. I think with that, both of our speakers, it was so nice talk, and there are so many take home messages from Dr. Kulkarni's that it's so important to have these asymptomatic patients to pick up. There was a very important topic on that differentiation of hypothyroidism and dysmorphism, simple from the USGs and the scan. There was a nice concept of this fetal hypothyroidism, that prognosis, that management, and everything, and that importance of testing. I think both the speakers has reinforced on the timely referral. That's so important. As a pediatrician, I think we should emphasize on that. Then coming to Dr. Ganesh presentation, and also that wonderful presentation on that HP axis, the natural progression of the natural process of the evolution, the importance of the central and the peripheral precocious puberty, and not to miss all those precocious puberty as a sinister marker of the secondary diseases that he emphasized again. And importance of growth chart, importance that we as a pediatrician, we get used to read the channel charts, very important. Thank you, Amuk, for this wonderful moderation. I would like to thank Pallavi ma'am, patiently waiting there, helping us every time whenever we are arranging these meetings. And thank you so much for all patient hearing, and good night. Good night to everyone.